All right. Hey ho, let's go. This is Resistance Radio, where natural selection selects resistance. And the rest of us are left asking who made the conditions for that selection possible in the first place. I'm your host, Mark Allen Derry. We've got federal overreach today. We got power grabs in public health data, a childhood disease that should not exist at this scale, a strep comeback that nobody asked for, and a 20,000 case Ebola warning that should be plastered on the front of every newspaper in the country. So strap in, there's a lot to cover. As usual, the through line is this: most of what we call a public health failure is actually a public policy failure. The difference is who makes the policy and who absorbs the consequences. Spoiler alert, it's rarely the same group of people. So please continue to like these. And if you're over on YouTube, please find me at the Dr. Derry at YouTube. I'm trying to also grow out the YouTube channel. Your comments mean a lot. I do try to respond to every single one of them. All right. So for our first segment, let's talk about your medical records and Kennedy's theories. Let's start with the story that has made public health practitioners' blood pressure spike without the assistance of antivirus, and it's made me have to take my lisinopril. So the wow. HHS, Health and Human Services. Wow, I'm such an optimist. I'm a toxic optimist. All right, Health and Human Services Secretary Robert F. Kennedy Jr. is pursuing federal access to most Americans' detailed, identifiable medical records. Let me say that again. He's pursuing federal access to your medical records, not in a national emergency, not for an active outbreak, but to research a claimed link between vaccines and autism. We're talking about doctor's notes, prescription histories, the stuff you tell your physicians in confidence in a room with a closed door because you trust the information stays in a specific professional relationship. And let me be very clear about what the science already says here. The vaccine autism hypothesis has been studied and let me just say, vaccine autism hypothesis has been studied in millions of children across dozens of countries and has not held up. This is not close science at all. This is not even a close scientific call. It's one of the most thoroughly investigated and repeatedly refuted questions in modern medicine. Public health leaders have already objected in private meetings, raising doubts about the legality of the request and whether the data would even be useful for the stated purpose. Now, here's our mic drop. We built these state health information exchanges to catch disease outbreaks early, to protect populations in a crisis, to save lives at scale. Using that infrastructure to chase a debunked theory isn't science. It's surveillance dressed up as curiosity. And when people stop trusting these systems, they stop sharing their information. And when information stops flowing, the next outbreak gets a head start. The people who will be most harmed by that erosion of trust, they're not in the room where these decisions are made. Let's shift again. We're now going to talk about Gavi, which I will explain in a second, which is the alliance of global vaccines, Kennedy, and the Rubio rebuke. So, speaking of rooms where decisions actually happen, on Capitol Hill this week, Secretary of State Marco Rubio told senators that the U.S. may restore its funding to Gavi, the global vaccine alliance that Kennedy pulled the United States out of last year. And before you celebrate, I want you to hold that thought for 1 second, because the fact that we are here at all is the story. Gavi has vaccinated nearly 1 billion children in low-income countries since its founding. It's one of the most cost-effective investments in history, and the USA just walked away from it. Now, 2 cabinet secretaries are publicly tussling over who controls the relationship with Global Vaccine Alliance, with Kennedy apparently still wanting, quote unquote, a leading role in the decision, and an HHS spokesperson said that both departments were engaging with Gavi directly. Think about what that means from the perspective of a health minister in a low-income country trying to plan the childhood vaccine campaign. Your largest historical funder dropped out, then maybe came back, and now 2 officials are fighting about who gets to decide. That is not a partnership. That's more like a weather system. The children who depend on Gavi-funded vaccines don't have lobbyists. They don't have senators. What they do have are program managers and cold chain logistics and community health workers, most of whom can't do their jobs without the funding that powerful governments keep using as a geopolitical football. Let's move over to Ebola, the price of not paying attention. So, as we know, the Democratic Republic of the Congo and Uganda are in the middle of a declared global health emergency caused by the Bundibugyo strain of Ebola. As of earlier this week, there have been 321 confirmed cases, 116 suspected, and at least 49 confirmed deaths. The numbers keep moving. CDC modelers ran projections. If only 20% of patients are isolated within 2 days of symptom onset, this outbreak could exceed over 20,000 cases in 3 months. To put that in context, that would be larger than entire cities. Most of the combined population of every confirmed Ebola case in recorded history, including the 2014 West Africa outbreak. The same models say that if 70% of patients were isolated quickly, there's about a 94% chance that the outbreak stays under 10,000 cases. The intervention isn't a new drug or a breakthrough vaccine. It's contact tracing, it's isolation facilities, it's community trust. It is public health infrastructure. And here's the part that the New York Times reported that should be in every medical school lecture, and that is healthcare workers in this outbreaks are hampered by a chronic lack of investment in high quality diagnostics for the very pathogen that surfaces in the world's most marginalized places. Think about what that means. The countries that have Ebola, they don't get the same diagnostic investment as the countries that have insurance companies. The pathogen hits the poor. The research budget follows the money. And the surveillance gap, the one created by the mismatch, is what allows viruses to spread unchecked. This is not bad luck. This is a policy choice made over decades by governments with enough resources to do otherwise. Measles. All right, so let's talk about measles. We've got 2,030 cases, and let's talk about what's happening in Shasta County. Again, 2,030, that is the measles case count as of June 4, 2026. Last year's full total was 2,228. So we are rapidly approaching that number. So let me offer you a way to think about this. Picture the student body of a mid-sized high school, maybe 1,500 to 2,000 students. Now imagine every single one of them infected with a virus that is airborne, that can linger in a room for 2 hours after an infected person leaves. And that was eliminated from this country in the year of 2000. That is where we are. 92% of the 2026 cases are in people who are unvaccinated or whose vaccination status is unknown. 21% are children under the age of 5. Kids too young to have completed their vaccine series, depending entirely on the immunity of everyone around them. That's also called community immunity or herd immunity. So this is not a mystery. Measles did not evolve around the vaccine. It did not acquire resistance. It is the exact same virus. We just decided as a policy matter and as a cultural matter to relax our commitment to vaccination, to broaden exemptions, to let coverage slip in communities that were already underserved. And here is the bright side, because we do need one. Shasta County, California, a rural vaccine hesitant county, got 9 confirmed cases of measles in January, and their public health team traced every step those 9 people took, contacted more than 600 potentially exposed individuals. That's 600 contacts for 9 cases. That is what functioning public health system looks like. That is shoe leather epidemiology. It's not glamorous, doesn't trend, and it doesn't happen without trained staff, a budget, and leadership that takes it seriously. Shasta County is the playbook. The question is whether we fund the players. Let's talk about strep. Here's a story that gets less attention than it deserves. A new study in clinical infectious diseases looked at pediatric invasive group A streptococcus That's the kind of strep that doesn't just give your kid some sore throat, but invades the bloodstream, the joints, the lungs. Before the pandemic, that's COVID, before the COVID pandemic, the incidence was about 1.9 cases per 100,000 children per year. That's been relatively stable over 15 years. During COVID, it dropped. Kids weren't in school, respiratory viruses weren't spreading, strep went quiet, zero point 0.6 per 100,000. Then it came back 1.5 in 2022, then 4.4 in 2023. That's more than double than the pre-pandemic baseline. Now, 88.7 of these kids were hospitalized. That's almost 90%. A third required intensive care, and the ICU admission rate trended upward over the study period from 30% in 2011 to 40% in 2023. This is not COVID. This is not Ebola. This is a bacteria we've known for generations, doing more damage than before, and children are requiring more intensive resources. The question we need to be asking is why? Is it post-COVID immune dysregulation, changed social exposure patterns, a shift in circulating strains? The study doesn't fully answer it, but we need to know, and we need to make sure hospital systems are resourced for it, not still running staffing models based on 2019 assumptions. And lastly, let's talk about some quick hits that are worth your attention. These are a few more stories that we need to talk about before we close. COVID vaccines and your heart rhythm. A large study of nearly almost 500,000 patients published in PLOS One found that COVID vaccination was associated with an 18% lower risk of developing new onset AFib or aflutter after COVID infection. That protection held across patients with obesity, diabetes, hypertension, kidney disease. The vaccine isn't just keeping people out of the hospital during acute infection, it's reducing downstream cardiovascular consequences. That is the conversation worth having with every patient who says that they're not worried about COVID anymore. Medical tourism and infection. A study in emerging infectious diseases found that traveling either across state lines or internationally for cosmetic procedures significantly increases the risk of post-surgical infections. While everyone focuses on the upfront savings, those infections land in domestic emergency rooms and hospitals. That is what happens when people can't afford the same procedures at home. The complication doesn't stay abroad, it comes back with the patient, and the cost gets absorbed by whoever treats it here. Flu vaccination and birthday timing. A JAMA pediatric study found that children with fall birthdays have an 8.6 to 12.5 percentage point higher flu vaccination rates than children with summer birthdays, because fall birthday kids are more likely to be seen by a doctor right before flu season peaks. The differences in parental attitude, it's child visit happening at the right time of year. That is a scheduling quirk driving a double-digit gap in vaccine coverage. Imagine what we could do if we design the system around patients instead of around appointment calendars. And lastly, Lyme's disease. Health and Human Services has set a goal to reduce Lyme disease diagnosis by 25% by 2035, anchored by $2.5 million in innovation and funding. Lyme's infects about 500,000 Americans each year. $2.5 million divided by about 500,000 patients is roughly about 5 patients per year. $5 per patient per year. We spend more than that on paper forms in a single clinic. I'm not saying the goal isn't worth having. I'm saying the goal and the investment are not on speaking terms. So here's the thing that connects all these stories, from medical records to measles, from Ebola in the Congo to strep in the pediatric ICU. Public health failure doesn't happen in a vacuum. It happens downstream of policy choices. It happens when exemptions get easier to get than vaccines, when diagnostic investment follows profit instead of burden, when the counties hit hardest by disease are the ones least funded to fight it, when we use public health data infrastructure for political projects instead of actual public health. The people making these decisions are largely insulated from their consequences. The people who aren't insulated are living in Shasta County without a pediatrician on every corner. They're the parents of a 3-year-old with measles. They're the child in the PICU with invasive strep. They're the community health workers in Mongabulu trying to isolate an Ebola patient without adequate PPE, adequate tests, or adequate support. The gap between who decides and who suffers is not a gap, it's a chasm. And naming it is the first step to closing it. You've been listening to Resistance Radio, where natural selection selects resistance, but public policy selects who has to fight it with the least. I'll be back tomorrow. Stay sharp, stay loud, and vaccinate like the evidence is on your side, because it is.